Patient-centered medical home is a new model of family medicine or of primary care in which a physician-led team gives more comprehensive and coordinated primary care. It's getting a lot of buzz right now with many of the changes going on with health reform legislation, and is really a way to build on the primary care basis to do stronger and more coordinated and comprehensive care, of course. The patient-centered medical home is defined by 7 different principles. 4 of these are considered care principles. The other 3 are considered more infrastructure principles, and these are some big changes in the way that we approach patient care. The 4 care principles are a personal physician, a relationship with a personal physician, which is kind of at the very basis of family medicine and primary care. A physician-led team, and the way we're doing that here is we have, of course, our front desk team. A nurse is a very important team member who is taking a bigger part of care of my patients now. And we've added a care coordinator who is kind of a new team member who helps us manage the patient's care when they're not in the office. The next thing would be the whole person orientation. This is a very key part of family medicine as well. This is, to me, is kind of the basis of family medicine and what makes it attractive to me as a specialty. Relationship is key, and looking at the whole person, not just an organ system approach, is what differentiates primary care from other specialties. So this is something we've done for a long time. Then coordination of care is kind of a new piece, and there are 2 parts to that. The care piece with the human touch is done by our care coordinator. And as I said earlier, our care coordinator looks through and tries to figure out which patients with chronic disease need a little more TLC and need more care and more management, and they help us in that aspect. They help get the patient in for their follow-ups, help with patient compliance, make sure they understand their medicines, do coaching with the patient, and also help the patient really understand their disease process better. What we're trying to do is have an activated patient who understands their disease process and can form a better team with, a team approach with our team. Now, the second part of coordination of care is considered an infrastructure change. And this is where we use things like registries, the electronic medical records, and computer and other things to kind of help us do a better job with patient management. And so far, we're seeing some big results already on how we're doing with getting our patients engaged. The next piece of this would be quality and safety. Quality, the way that we make quality better in this setting is that we go through a rigorous certification process to become a certified medical home. All of our doctors have to go through continued board certification in which we do quality improvement programs, and we make efforts at developing tools that use evidence-based medicine to provide the best and most up-to-date care for our patients. There are a lot of things in the electronic medical records that help improve safety because they give us feedback. If we write a medication for a patient who's on a long list of meds, we get a little pop-up that happens on the computer to tell us that there's a drug interaction, that maybe we need to consider another medicine. So there are all kinds of nice little bells and whistles like that help us. The next piece would be enhanced access, which I think we've always done very well in our particular office, but enhanced access means if a patient calls today and wants to be seen by their provider, we make a big, we do the best we can to make that happen. Part of that is using something called open access scheduling, where you work down your backlog of patients and make a big effort at leaving at least half of your schedule open on a daily basis. I tell you, this is a big patient pleaser, and it makes for better care. Some other tools that are helpful are we do something called a patient portal. With our particular system, it's called MyChart. The patient can use their computer to go to this patient portal on the internet, get their lab results. Say they had a physical with me today, I can get their lab results to them faster. If they have questions, they can shoot me an email, and I can answer between patients or when I have time. And to me, it's much less disruptive than the phone, and it's a nice way to communicate with patients and sometimes alleviate having to work through someone else answering the phone call and then sending a message to me. So those are some new ways to improve access with patients. The last and final piece of this is a payment system which recognizes the added value of a more comprehensive approach to patient care. We don't see a lot of that in this country yet, but the thought would be that we break away from the traditional fee-for-service type of payment system and do something that's more of a hybrid approach. In this hybrid approach, there would be a monthly medical management fee, which helps us do a lot of the other things that happen outside of the traditional patient visit, as well as some payments for things like quality improvement, and if we're doing some things, say, keeping our patients healthier so they spend less time in the hospital, there would be some quality payments for that too. So if you look at this big ball of wax, it's one way to try to improve the model of medicine that we're using and making it more proactive rather than reactive, and making it more continuous than episodic.